if you have questions, please don't fail to tweet us up here at the front. I'm sure that we'll be very happy, the speakers will be very happy to provide the answers to make your day perhaps a little bit better after hearing all of this. Our next speaker is Dr. L.D. Britt, who really doesn't need a lot of introduction to this group. I just want to say a few words. He is a valedictorian of his high school class, Booker T. Washington High School, and he received a BA degree from the University of Virginia and was a member of the Raven Society. He graduated Harvard Medical School and Harvard School of Public Health. He's had extensive surgical and clinical critical care training. Dr. Britt has been involved in organizations too numerous to count. He serves on numerous editorial boards. He is involved in several national and international organizations, including the Alpha Omega Alpha Honor Society, Society of University Surgeons, Southern Surgical Association, the Halstead Society, and the American Surgical Association. The list goes on and on and on of his accomplishments and kudos. One thing I would like to mention, because I'm sure you're all very familiar with him, which I didn't know and I think is a very interesting mark, and that is that Dr. Britt received an Emmy from the National Academy of Television Arts and Sciences for his contribution to the television special, Youth Violence, A Call to Disarm, showing the expansiveness of his career and his ability to work in and outside of the fields of medicine. It gives me great pleasure to introduce Dr. Britt.
It is a real pleasure for me to be here. First, let me say I am a card-carrying AMA member. I do want to say that we're a few minutes behind, so what I'll try to do is be succinct so we can go to the Q&A. I agree with Dr. Apelker. I want to thank Dr. Lerner, I want to thank Dr. Cutter, and I also want to thank my distinguished colleagues, Dr. Kamel and obviously Dr. Apelker. Well, you know, medicine, my job, I was assigned to represent the patients, the impact of the Accountable Care Act. A lot of people drop the PP, but it's patient protection. So first, let me just set the landscape similar to Dr. Carmel. This is our landscape. We have 315 million people in this country. We have close to 800,000 physicians and 6,000 hospitals. I don't think anyone would deny that we have a worsening healthcare crisis. Dr. Kamel made a great argument for that. And I agree with him. This is unsustainable, the healthcare expenditures. We're the only trillion-dollar industry in America. You look at agriculture, that's about $400 billion. The only real trillion-dollar industry in the United States is healthcare. And we're not getting our money's worth. Per capita, this is an unsustainable model here. And I don't care what you say. We have a lot of MBAs and medical executives, but at the end of the day, market forces cannot affect healthcare expenditures to the point that we can say that that's dependent on the market forces. That's not part of the formula in healthcare. I don't think anyone would deny the fact that we have a medical arms race. You can go to the big cities and see that. That's contributing to these expenditures. And there's a ruse. And again, my job is to represent the patient, and I'll get to that. But at the end of the day, we're spending $1 out of every $3 on unnecessary, unproven procedures and devices. We have an overwhelming administrative overhead, and this is something that if you're going to have a true reform, this is going to have to be addressed. Again, we have waste. Again, my job is to present the facts. You see here 40% unnecessary care, 19% fraud. I'm sure some people will quibble with the percentages, but at the end of the day, this fraud, I'll just take one aspect. Look at the fraud. This came out just a few months ago. They had 9 cities. And again, you can say, what's the real impact? And I agree with Dr. Carmel. I think we have money in the system to fix all of this. But at the end of the day, we have $80 billion in Medicare fraud alone. And I hope no one is from New York. I have to apologize for Dr. Carmel. I know he's from New York. But you have 15 to 20 billion of that fraud in New York City alone. And so the consensus is that we have a healthcare system that's broken. So you can say what you want about, obviously, the Affordable Care Act, but we needed some sort of healthcare reform. The steady state we had could not be continued. So I would like to focus my few minutes on not the politics. There is a disconnect between the healthcare reform, But the Patient Protection and Affordable Care Act, in all fairness, there's a lot of acronyms. The acronym is PPACA. Some people call it Obamacare, healthcare reform. We know when it was enacted, but it was done based on the backdrop that I highlighted. But in all fairness, and to be truly transparent, the American College of Surgeons did not support this bill in its final iteration. We officially opposed it, but we are supporting it because it's law now. Having said that, this current healthcare reform, the Affordable Care Act, will not solve rising healthcare costs. It would not effectively highlight transparency. We will still have 50 million people who are uninsured. We will still have a growing number of Medicare beneficiaries. Dr. Kamel made a good argument for that. We will not fix the SGR. It has not done that in this reform. And obviously, I think the disparities in health care will continue to grow. So this transformation, in all fairness, started way before this health reform, Obamacare, or the PPACA. Started even before this. But the Crossing the Quality Chasm talked about the need for transformation. They highlighted that there needed to be evidence-based care, IT, aligned payment with quality, something that Dr. Pelko highlighted, and obviously prepare a workforce that's obviously declining. You know, this is a great book, and this book pretty much could highlight what we stumbling with in healthcare. Rebecca Costa, in her book on the Watchman's Rattle, talked about that instinctively reacting to symptoms is what we're doing in America now. That we are looking at quick fixes, and that we have lost the history of this country as being able to tackle big problems, that we have lost that ability. Well, I'm not that fatalistic. I'm not sure we're at that point, but I got to tell you, there are a lot of people that will argue for that stand, that we have lost the ability to tackle big problems. This is just one chapter of healthcare reform. The Patient Protection and Affordable Care Act expands access, improves quality, and contains growth. Now, you look at that, in all fairness, those goals are not consistent. And I agree with Dr. Kamel. You got 30 million people who are added to the ranks of the insured. You have new public programs. You have new coverage mandates. I'll go back to that slide. There's no way you can expand access, improve care, and contain growth with this model. Again, it set the stage for fundamental changes, and we need those changes. Payment changes, well highlighted by Dr. Opelka, quality changes, delivery of services. But this is not a recipe for containment. If you really look at it, you're going to add more money to the system. And revenue provisions will help, but it will not be enough. And cutting rates is not the answer. And so in all fairness, as far as what patients will get out of it, yes, there'll be coordinated care and long-term healing relationships, but I think that will be good for the patient population. As far as bundle payments, at the end of the day, I think we do need to work as teams. I'm not sure how this will pan out for optimal patient care. I think the jury is out there. Obviously, readmissions, reducing payments, and for readmissions, I'm not sure how this will impact patient care. I will hope that it will be positive. But again, you know, it's hard to say. The hospital-acquired conditions, they're going to reduce, obviously, your payments if there's a hospital-acquired condition. I'm not sure that some of these conditions might be hidden and might be camouflaged. I'm not sure what the impact of that will be on patient care. I don't think it will be positive. And again, you know, you look at the transforming the delivery system. The Human Services Secretary shall establish the shared savings program to promote accountability for patient. On surface, this sounds good, and I think on surface, this should be a positive impact for the patient. But looking ahead, this is where we are going. And the current Affordable Care Act does not blunt this at all. By 2018, some of us will be retired, not myself, you will have $4.35 trillion industry. Now, as far as I'm concerned, there are 4 forces that influence healthcare. 4. And you can look at it. Expanding knowledge base, information technology, chronic care needs, and payment policies. Let me just tackle the payment policies. This current Affordable Care Act is shifting from volume-based to value-based healthcare, and I support that. And I think if it's done in the right sort of format, it will be a positive for the patient. The new reimbursement approaches will tie quality to the payment. I think if it's done correctly, I think that would be a positive for the patient. As far as the bundled care, I think we have to see with that. For example, this new Affordable Care Act has a component for general surgeons in the rural areas. You've heard about this. It's called the health professional shortage areas. And again, it's hard for me to define, it's certainly not where I live. There'll be a 10% bonus payment to be paid on a monthly basis, a quarterly basis to the physicians. How this will impact, hopefully it will have more people going to the rural areas, and the patient sort of impact, the impact of this on patients should be positive, particularly in those settings. Now let's talk about IT, which I'm the most critical of. If you look last century, scientific knowledge doubled every decade. They have already predicted that it will triple every decade this century. Now, even the bright minds I see in this audience, there's no way that we can process and then implement that new knowledge unless we have some sort of IT system. You can talk about Six Sigma all you want, but Six Sigma means that out of 1 million transactions, you have less than 4 mistakes or defects. If we already have 1.7 and 1.8 mistakes per patient per ICU, we're not even close to this. And we're not going to get close to this unless we obviously embrace IT. And this new Affordable Care Act does talk about the role of IT. Again, error reduction, enhanced healthcare efficiency and cost and quality improvement. I agree with Dr. Pelka and Dr. Carmel. We need a system to help us, and that system is going to be IT, which we have really done poorly in as a nation. If you look at the other countries, you can't see it, but to your left is Sweden, and all the way to your right is the United States. Less than 20% of physicians utilize electronic medical records. You hear what Dr. Carmel said, if you don't have an EMR sort of efficiency, you're not going to be part of this system. I always like to show this slide because we're not by ourselves. Canada's behind us. We've got Spain behind us, France, and Portugal. But if you look at quality, you're not going to be able to adequately track performance and quality without IT. Again, a component, a prelude, the health information technology will help us improve efficiency and effectiveness of care. Now, again, I can go through this, but these are some of the components of this new act, the incentives to implement the EHR. Obviously, there are 3 main components of meaningful use. In other words, you have to be able to certify EHR into a meaningful manner as far as e-prescribing, use of a certified electronic health record for technology for exchange of health information to improve quality. I believe in that. But at the end of the day, we have done little. And I've said this, I just want to say it publicly. I think that the death knell for the private practitioner, the 2-person group, the 3-person group, the big group, is going to be electronic medical record. It is cost prohibitive. It is driving some practices to go and be employees of the hospital. And then obviously, of particular interest, obviously, is the expand the eligibility of Medicare and establishment of health insurance exchanges. I can't leave that out. But this will result in an influx of patients into the healthcare system where it's already straining the providers. I don't think that's going to be beneficial to the patients. We have a workforce shortage, and no one is looking at that. I would be remiss if I did not talk about the tort reform component. And there's something in this new reform, this PPACA, where some grants will be out, but those grants total up to $50 million. That's not a lot as far as states, as far as alternatives and ways to deal with tort litigation. I don't think this is enough. Well, at the end of the day, you know, people have challenged this. Everyone said this is not going to be repealed. Let me first say that. What they might do, obviously, is not fund it, but it's not going to be repealed. And I'm not proud of this. My state, they had the first federal ruling in a legal challenge to this came in my state. The U.S. District Judge, Judge Hudson, denied the Justice Department's request to dismiss this suit. Bottom line, this was recent. We had a 3-judge panel for the 4th Circuit Court of Appeals that said the state did not have, my state, Commonwealth of Virginia, did not have the authority to challenge the law. So I really don't think this will be appealed. And let me finish off with this because I know I'm running out of time. There is a hidden chapter, something that I did not see that I think will help patients. There's something that is hidden in this reform that needs to be out. It's health literacy. If you look at it, again, we can go through all of this. I'm not saying that people are not bright, but at the end of the day, these are the facts. You look here, we have a United States dropout rate, high school dropout rate over 30%. And this is not something I made up. This is a real street sign. And again, this health literacy, actually, we have professionals being confused about some of the instructions. When you have 90 million adults having trouble understanding and acting on health information, I don't care what we do as far as the reform, if we don't address that, it's all for naught. Providers need some sort of health literacy training. I'm not sure that's part of the bill. This is from the RAND Corporation on the West Coast, because we're on the West Coast, I'll highlight this. They said that Americans receive about half the recommended care, half of the recommended care. So we can talk about the House of Medicine. I'm a card carrying member of the AMA. We can talk about the House of Surgery. I mean, here's the demographics there. We don't have a lot of people in the houses sometimes. But this train has not left the station. I do think, at least on surface, there should be a positive impact on the patients, but I think the jury is still out. Thank you very much.